And Howard, do you want to start off this week?
Sure.
All right, I'll make you the presenter. There we go.
Okay, let me start with this one. This was from just a moment ago, and the indication was question mark flipped port. So I went back and found an image obtained earlier this year in July when the catheter was placed, and I will show you mag up here how different it looks. So first off, if you look at just the overall configuration of the port, it has changed. It isn't positioned quite the same way, and it's also angled a little bit differently compared to before. That portion between the port itself, or the opaque portion here, and the beginning of the catheter has changed as well. And now when you zoom up further, which I will do, and I hope this shows, I'm going to try and change the contrast. In zooming it up quite a bit, I've actually changed it such that it's going to be a bit hard. And of course, this is white, black, black, white's changed. But previously, it says CT, CT, CT. And when you look at that now, you can see that the C and the T are now backwards. So it's upside down, CT. So that's also an observation one can make to indicate that it's flipped completely around so that the needle accessible portion is now facing the chest wall, and no surprise that they were unable to presumably put a needle in there to actually use it. So in several ways one can judge that this has flipped, and it's flipped over completely by, say, 180 degrees. By looking at the CT and the CT back to front. I don't remember what the product name of this particular port is, but you can see that there. David, I think you'll like that one. You've shown us these before, right?
Yes, indeed. Nice example.
Yeah.
It's a great one.
Very nice. Okay, I'm going to show you a really interesting case here. So this relatively young person came in, and the history we got was likely cardiomyopathy attributed to, perhaps at least in part, methamphetamine abuse. So the findings right off the bat are florid interstitial lung edema, a very nice example of peribronchial fluid cuffs, septal lines, and subpleural edema related to the fissures. Pleural effusions, right slightly bigger than left, and indeed the left ventricular chamber is particularly enlarged, and poor contractility of it and ejection fraction was subsequently shown to be low on cardiac ultrasound. So we have hydrostatic lung edema. Now I'll go back to initially the lung windows to show you that, interestingly, there is more interstitial lung edema and even ground glass opacity, consistent with foci of alveolar edema in the right lower lobe compared to the left lower lobe. Now I'm going to show you, and I'm going to make this up there and make this a coronal as well to show you a really interesting finding. So let me get to the right place. Now right here, and I'm going to zoom in here, in this right lower lobe pulmonary artery, you can see there is a filling defect. There it is there. And it's harder to perceive actually on the axial than it is on the coronal, but it corresponds to this region down here. So here's the filling defect. Now, when I bring up the pixel values, you'll see that this here is in the range of 250, 248, 190, too high for an embolus, which is in the range of 30, 40 or so. So it is black smoke. Now, let me just dismiss this one for a moment and also show you that when you look at even the downstream vessels in the lower lobes, comparing right versus left, you'll see the arteries, veins and arteries are opacified nicely. But down here, beyond this point, more inferiorly, you can see that those vessels here are not opacified in the same way. And in fact, they're a little bit distended. So I think the very likely explanation here, and it can only be presumptive, is that we have a bronchial artery to pulmonary artery communication, congenital. There is passage of the blood from the bronchial artery into the pulmonary artery and downstream. And because, according to Starling's equation, if the systemic pressure downstream is high, that nicely explains that we'll have more lung edema there, because capillary hydrostatic pressure is going to be relatively high and higher than the left side. So I like to think that the explanation for these findings is the congenital bronchial artery to pulmonary artery communication and the associated flow phenomenon and the black smoke from the relatively unopacified blood coming in via that bronchial artery. What do you think?
I think that's a pretty good explanation from that. I know we've seen a couple of other cases of bronchial artery inflow.
Yeah. So we have a shunt, but I don't think it's of a magnitude overall that it needs to be proven or taken care of as such.
And I suspect, and I think I've read it somewhere, that these communications exist normally and different changes in the lung can sort of accentuate them. Oh, Seth, do you remember, I say Seth, I don't know if he's got audio. Do you remember anything about these normal intrapulmonary, pulmonary arterial and bronchial arterial communications? He's grayed out, so I don't know what that means.
Okay. So we may never get, definitive proof. I don't think we need it, though. I think that's a really strong presumptive diagnosis. And he's got other substantial problems separate from that. All right, let me show you. Well, again, I'll show you a couple of these because maybe some folks that are watching like to see diaphragm evaluations. So here's the context. Here is a prior exam in this patient. And what happened between these two and more recently was a relatively minimally invasive procedure to address the mitral valve. Let me bring this up to see if I can show you that. It's really subtle, but there is a mitral valve annuloplasty device in here. It's kind of subtle. So that procedure was performed as a little bit of subcutaneous emphysema. So an invasive procedure was done, but not via the sternum, via kind of a thoracotomy. And you can see that when we compare the radiograph now with that obtained prior to the procedure, that the right hemidiaphragm is elevated. Now I'll show you that that new elevation of the right hemidiaphragm persists. So now we're into May, and here is the elevated right hemidiaphragm. And I suggested the possibility of iatrogenic phrenic nerve injury during that procedure. And now I'll show you some images from the fluoro. So let me show you these two. So on the left, and I'll play this, will be a single deep inspiration. Sorry, not that one. This one first. So I usually let the patient breathe in, and then I'll stop this for a moment. Just for those of you that don't do these very often, when I give the patient the instruction to, in this case, take a deep breath, I give that instruction when the diaphragms have moved up and the patient is ready to take in the next breath. So you'll see a couple breaths, and then you will see the deep breath there. So I'll let that play one more time. You'll see a couple normal breaths, and then I'll say, take in a deep breath. Nice downward movement of the left, not of the right. Now this is going to be the sniff, and my instruction for the sniff is going to come towards the end right about now. Okay, I'll stop that because I'll play that slowly, and you'll see that there's a nice paradoxical elevation that you'll see really nicely there, right there. Let me just play it a bit slower, right there. So confirming paralysis of the right hemidiaphragm, paradoxical elevation with the sniff. Any comments, David?
Yeah, so paradox does not mean paralysis. It just means relative weakness. So they both start with P, but paradox does not equal paralysis. So it's like arm wrestling. If you have a contender like me who's skinny and you have a muscular dude, there will be paradoxical motion of my forearm. It will go backward because the other guy is going to overwhelm me. But it doesn't mean I'm paralyzed. It just means that I'm weaker than the buff dude. So paradox equals weakness, relative weakness, not paralysis, as long as people don't get the wrong idea.
Yeah. But of course, for the totality of this case and all the other findings, pretty sure that it's a phrenic nerve problem.
Yeah. So the critical thing for paralysis is the lack of motion on that slow, deep inspiration. That's what establishes paralysis.
I'll just play that one again.
It just sits there.
Nice example. Right.
And as opposed to eventration, the elevation goes all the way to the posterior chest wall. So that's characteristic of paralysis.
Yep.
Eventration could have some anterior elevation, but normal height or approaching normal height posteriorly.
Yeah.
Very cool.
I do a lot of these now in the lateral projection. I find it much easier to see the entirety of the hemidiaphragm on the lateral projection. That's become my usual practice now.
Good, very good. So I include the lateral. So the lateral is part of it, but I do the frontals as well. I also do supine imaging.
Yeah.
Frontal only. So very helpful again with eventration versus paralysis is that you can have the anterior eventirated portion of the right hemidiaphragm may show no motion on a deep inspiration, may just sit there. But if you observe it posteriorly on your lateral view, you will see that there's vigorous motion posteriorly over the vertebral bodies. So that you only if you don't have a lateral, you will confuse eventration with paralysis.
Yep. Well, here is a patient with a device, but it's not a pacemaker, cardiac pacemaker, of course. It's a deep brain stimulator. But take a look at what has happened here. April versus June. Let me mag in here quite a bit. This can has twisted. And look at the degree of twisting of the leads that go superiorly. Look at that. Now, I don't think this person that I know was fiddling with this. I think this just happened spontaneously. But if you look at these leads, just look at the degree to which the leads have all twisted up and coiled up here. And you can see there are a bunch of leads behind here, behind the can. And if you look at this can now, all the leads that were sort of redundant and coiled back there are all coiled on themselves back here now, all in that location. So let's go to the lateral to take a look at that too. So kind of the analogous, thing. They're all the twisted and coiled up leads right in here. So I don't know what they're going to do with that, but they're all coiled up and twisted.
Did the device stop working? Is that what triggered the imaging?
No, I don't know, actually. I don't know that. I don't know what happened. It was an observation. I don't know that. I should, but I don't.
It could have pulled his skull on that side, and he would have had a torticollis maybe from a tension on the cable. That was a joke.
Oh yeah, talking about acute case, how would you describe this one? Bilateral hangman, would that be okay?
Are they lifting weights?
I don't know the nature of the lung disease, but I thought that was pretty good.
We had one time one that had skulls hanging from it, so we sent it over to the neuroradiologist for a consult. That was years ago.
That's cool, huh? Okay, we don't need to look at that anymore. Okay, how about, well, let me stop there, and then I can show a few more if time permits, or another week.
Okay, that sounds great. I see we have Seth, Maya, and David. If anyone would like to go next.
I'm happy to.
All right, I'll make you the presenter.
Thank you. Okay. So I just have 2 cases this week. So this is a patient that the study actually got sent to me by one of my abdominal colleagues recently. So this is the patient's original imaging. We can see as we scroll through, this patient has had prior coronary artery bypass to the left system. However, their right coronary artery, very severely calcified, and then as we come out distally, really hard to tell whether there's any actual opacification. Then we get out even more distally, and there's essentially no vessel left. So this patient had a known chronic total occlusion of the RCA. And cardiology took them for revascularization of this chronic total occlusion. And pretty immediately after the procedure, the patient got, I believe, hypotensive. And so they did an abdominal CT to look for a retroperitoneal bleed, which the patient did not have. But the abdominal CT caught the heart, or at least part of the heart, and we can see around that RCA, which now has a stent in it, we see this large amount of stranding and sort of hematoma in the area where they did this revascularization, this percutaneous revascularization of this total occlusion. And so when they do these, right, they're just sort of poking with the wire and obviously can get outside of the expected course of the vessel and cause this hematoma around the area. This is just something that I had never actually seen the immediate post-procedural imaging of before. I'm not sure if others have as well. Presumably, this is the expected appearance, given that degree of sort of macerating of tissue that they do. But I would love to hear if anybody else has seen this before or seen sort of the progression, whether this all goes away eventually. It does look like it's causing some mass effect here. Mm-hmm.
Yeah, this is epicardial hematoma associated with revascularization. It's not common. It's not really normal. I've seen it worse than this. And if you asked the surgeons and if you had a gross picture of it, you would literally see what looked like a big blue tube, because it looks tubular, like along the pericardium. So if you're looking at the pericardial surface, looking in the heart, it's just a big bruise, basically, that looks like that goes all the way. I've seen some pictures of it. It's fascinating, but this isn't expected. And so was it just a stent that led to this?
So I think there was no, the entire RCA was occluded before they started. And so they were just sort of like essentially dissecting down to create a tunnel, and then they put a stent over what they had created.
Yeah, so they probably led some, there's some leaking, or some bleeding out in that. I mean, that's why they usually don't do this, but that's, no, I've seen it before. I've seen it with both. I've seen it once with the TAVR and a couple of times with revascularizations.
Interesting. Cool. Excellent. And so I have one other quick case. This is one that's an older case that I just came across again. It is possible that Travis showed this a few years ago from my institution. But we have a patient here who, this is their chest radiograph. You can obviously see that there is a large lesion here in the left upper lobe of the lung here. If we look closely, you can see that there is air in it, but also some areas that look more like soft tissue. And if we go to this patient's CT to look at this lesion, this is what we see. So there's a large cavity with all of these sort of folded membrane within it. And the relevant history from this patient is that this patient grew up in the Middle East and recently immigrated to this country and has this. And so what this turned out to be is pulmonary echinococcus. And so this is sort of essentially the equivalent of that water lily sign that we see sometimes on abdominal imaging of the echinococcal cysts, where all the membranes have sort of sloughed off. But I do have the patient's pathology report from when they had a left upper lobectomy to remove this large structure, which was compatible with a hydatid cyst and contents, and they even found some scolices in it as well. But just not super common.
It's strange that it sort of leapt to this left upper location rather than being along the right hemidiaphragm, which is typical.
Right, and the interesting thing was there was nothing in the liver in this patient. There was nothing intra-abdominally. It was just this one lung lesion. It was very odd. But yeah, not a super common infection, but a good example of it.
Yeah, I showed a case. That's a great case. I showed an example maybe a couple months ago of like 4 hydatid cysts in the same patient. It can be multiple, but yours is a really nice example of a collapsed one.
Yeah, very much so.
All right. Well, thanks for sharing, Maya.
Yeah, of course.
Very nice cases. All righty. David or Seth, do you guys have anything?
I've got a couple.
All right.
Yeah, I can wait. I mean, I just have a couple, but I'm happy to wait.
Yeah, we got lots of time. So. There we go. Thanks, David.
Yeah, I didn't see it at first. So I saw this radiograph in May, one with a big cavity here with a fluid level in the bottom of it. And on lateral view, you can see it's sitting back there, probably in superior segment of right lower lobe. The lungs are not normal elsewhere. There seem to be thickened bronchi going up here and little dots and maybe bronchial wall thickening in the left mid lung and base too. So a current CT to this one is roughly here. Let me pull up the CT. Okay. So I think this is the current CT for that. It matches that chest radiograph with this big angry looking cavity here, but then lots of bronchial disease elsewhere. This woman has a history of MAC that goes back to the early 2000s. There are no known risk factors. She doesn't have any known immune deficiency. She's been on and off medications with lots of side effects. The medications for this are sometimes worse than the disease. But at this point, she did benefit from going back on therapy and stuff. So this is MAC with an abscess. Now, you know, in this location, you kind of wonder, is the abscess really caused by MAC, or could this be a different bug? Could she have aspirated something, or could she have a MAC lesion down there that got secondarily infected with something else? So if we go back to an earlier CT, we can see that precursors to this lesion were there before. Here's a smaller abscess cavity, and before that we had, this is now a few months before, had this is way back in 2011, this one. There was nothing in that location, but there was the earlier finding of MAC. This is 2011 imaging here with a classic middle lobe and lingular concentration of lesions. And here's the earlier precursor to this, what became a cavity. So this has been smoldering there for months or years. It's not as if this was a newly arrived thing down here. So this is probably part of her MAC. It could be MAC cavity, and then it could have some other bugs in it. It did get better on subsequent imaging. In my experience, the earliest manifestations of MAC are not in the middle lobe and lingular where we see it when it's taken hold, but in this axillary aspect of the right upper lobe. So this is the classic location where I've seen the earliest findings, usually small airway shadows, little tree and bud things in this region here. So this woman isn't showing that characteristic distribution, but I've seen that so many times in the earliest manifestations of MAC, is that it likes to be near the right axilla. And you know, you can sort of say that, well, that's where the airflow is going to carry it, because it's usually a straight shot from this right upper lobe bronchus, just sort of pointing the organisms in this direction when you inhale. Okay, so this was a case of bad MAC with a big abscess cavity in the right lower lobe, and it's better on intensified therapy for her MAC. Okay, and then I want to come clean, and I want to go back to this case that I showed a couple of months ago of this huge low attenuation lesion here that has low Hounsfield units around 20 in this roughly 20-year-old woman. And it has some septations in it and things like that on MR, which I'm not showing today. And it looks just like several cases that I found, some cases I found in the literature of chordoma. And chordoma can occur without spinal lesions, or without spinal lesions being manifest. And so one of the cases in the literature was also a 20-year-old, I think, woman, had very similar findings to this and so forth, and very similar MR findings with thin septations in this lesion. So Maya showed a case of chordoma after that, and it did have the thin septations and everything like that on MRI, as I recall. And so I was really set on that. Plus, I needed more cases of chordoma for my teaching file. So I was very eager to have this be chordoma. Well, the results are in. They finally resected this thing, and this is a lipoblastoma. And there was no fat on MRI. There had been earlier entertaining that this was a liposarcoma, but there was absolutely no fat on the MR study. It turns out
how old is she?
She's 20, roughly 20.
That's crazy. That's a baby. That's like a very young baby tumor.
Yeah. So this turns out to be lipoblastoma, which I talked to the pathologist about, and the pathologist says lipoblastomas can be fat poor. So they can have no fat in them, no macroscopic fat, but they're still made up of fat precursor kinds of cells. And they described this as mixoid. The pathologist described this resected specimen as mixoid, which accounts for the low CT numbers around 20, but they didn't describe it as fat containing. So what I wanted to be a chordoma turned out to be a disappointing lipoblastoma, but that's not a bad thing because I've never had a case of lipoblastoma before. So can you please everybody mobilize your lipoblastoma cases and show them to me. I've never seen one before. Has anybody else seen a lipoblastoma?
Never.
An adult.
Yeah, I mean, I lecture on them at the ARP, so I have a bunch of cases, but they don't look anything like this. They're usually fatty lesions in the neck or in the superior media, in the mediastinum extending from the neck or in the arm. I've never seen one look like this.
Okay.
Is it from a pathology standpoint, is it pretty much, if they got a complete resection, is it bilateral?
Yeah, it's a benign tumor. It's a benign tumor.
Oh, it is a benign tumor. Well, that's better than a chordoma, which can recur and be aggressive.
That's right. Yeah.
Yeah, no, they're just these squishy masses, and they like mom feels them or something, or even if they don't, they incidentally found, they take them out, they're benign.
Now, David, do you know how they got this one out? Did they do a lateral thoracotomy or a?
They did a clamshell. Okay.
Gee.
So lipoblastoma, guys, not a chordoma, but it's my first. So Seth, those were babies that you saw it in before, is that right?
Yeah, they're young. I mean, they're 2, 3, 4, 5 years old kind of thing.
Yeah.
So I think they can recur if it's just like any tumor, like if you don't get the whole thing, because a lot of times they're a little more infiltrative-y, meaning they're benign fat, but they're hard to get out. So if you don't get the whole thing out, it can come back, but it's not like it's not a lesion that metastasizes.
Right.
So,
and I think, by its size, this lesion has been growing for a long time. So I bet if we'd had a radiograph when she was 5 years old, we might have seen it already at that point.
Oh, sure it was. Yeah, because they're slow growing. I've never seen one that, ones I have they're not small, but they're nothing like this.
Gee.
And all the ones I have clear fat in it. So yeah.
Okay, so those are my cases this week.
That's a crazy case.
That's a good one to end on. Seth, did you want to go?
Yeah, sure. Okay, let's see here. Oh, this was a good pickup by one of our attendings. So this patient has this very ugly fracture. It was an elbow at some point in time. You can see there's a lot of gas in and around the elbow. I don't remember what kind of accident it was, maybe an ATV accident or something. And, it's not uncommon that we see some air in the PA from injection, but there's a lot of air here. I still would have said maybe it's injection related. But interestingly, if you look, there's air. So the fracture was on the left, the injection was on the right. But there's air actually in the left, I don't know which vein that is. It's beyond the axillary vein, brachial vein, I'm not sure, but there's actually air. I'm sorry?
Yep, brachial.
Yeah, there's actually air in the brachial vein coming from that open fracture. And then here's air in the brachiocephalic vein and then air in the PA. So this was an open fracture leading to a decent amount of air embolization. Nothing that was, the patient was asymptomatic from it, but I don't think I've seen that before. I was impressed. Anyways, I thought that was interesting.
Wow.
Which case is this? I don't remember. Oh, I like this case. I enjoy this. So here's a patient, nothing groundbreaking, but I just liked watching the evolution of these things. So this is during COVID, right? So early patient comes in, short of breath, COVID, somewhere in the probably DAD, but maybe OP, somewhere in the acute lung injury spectrum. Here the patient is a few weeks later, and you can see she's got the good old trach, and now she's more in the, whatever you want to call it, organizing phase, DAD. Doesn't look good. She's trached in the hospital for you know, a good month and a half, and then we had a follow-up of her today, and I'm always impressed. I mean, we've all shown cases of people with trashed lungs, but I'm always impressed by, you know, the lung's ability to heal itself. So this is her now, a year and a half later. So really remarkable. I mean, there still is clearly some injury or some fibrosis at this point, some scarring, peribronchiolar, but really impressed about how well the lung was able to basically repair itself from that severe lung injury. And, you know, I'll show another thing. The lung volumes also are dramatically improved, as you would expect. I did a volumetric just for my own. I just did a volumetric assessment of the lungs, and the lungs have nearly doubled in volume since she was in this, you know, because the main component of this injury is lung collapse, and her lungs have really kind of rebounded. So anyways, I really like seeing those follow-ups. Too often it's people going on to transplant or totally destroyed lungs, and we forget that the lungs can repair themselves. And this is an intro, and this is just goes along with, you know, I had another case this morning where a patient was labeled as sarcoid, and there's, you know, pulmonary sarcoid, and labeled in 2007 as pulmonary sarcoid. And of course, now she forever is known as having sarcoid, although there's never any evidence of her ever having sarcoid. She doesn't look anything like sarcoid. This is a different case, but kind of the same vein. So this is a patient with weird findings beyond the autopneumonectomy on the left. So the destroyed left PA, there is a pulmonary artery there. These don't look like bronchial collaterals, although there are pulmonary bronchial collaterals. There is a destroyed PA down there. The left lung is destroyed. Patient also has, and again, I'm not sure how all of this is related. Patient also has a little bit of a coarc, you can see here. But then on top of that, so here is today's study with the coarc, with the destroyed PA. It's not a PA. I've shown cases many years ago as a pulmonary coarctations, which this isn't, because those are usually more central. But what I wanted to show is this patient had a study in 2009. He had the coarc and the kind of destroyed left lung, but the rest of the vasculature looked okay. And then here he is now, and starting in around 2015, he started developing signs of a vasculitis. So you can see here circumferential soft tissue around the aorta, as well as circumferential soft tissue around the some of the pulmonary artery branches. Now, the point being about people getting labeled as something, I just looked at it, and somehow she's being labeled as Behçet's because someone read an MRI 7 years ago or 8 years ago and said, oh, there's involvement of the aorta and pulmonary arteries, it's likely Behçet's. But the patient doesn't have any genital ulcers, any skin rashes, any eye issues, which are required for the diagnosis, but still now has a diagnosis of Behçet's, even though this is clearly not, in my mind, not Behçet's. You know, it is a vasculitis, and it's a large vessel vasculitis. Who knows what it is? The patient hasn't undergone biopsy. I mean, I would guess if you're in a guy's 40 years old, you know, if you're going to put a name on it, it's really a large vessel vasculitis. Some medium vessel involvement's probably Takayasu, but who knows? I really don't care about labeling them too much. But anyways, not sure. I'm still not sure what the left PA, if that was due to a very early manifestation of vasculitis. Again, the vasculitis didn't pop up till around 2015. And supposedly this finding had been there since like 2006 or 7 when he first underwent imaging, so probably longer than that. Or if that's related somehow to the coarc. Anyways.
So Seth, what do you think destroyed the left lung? I mean, it looks like I've seen people look like this after TB, for instance.
It may have been TB. He is a it could absolutely be TB. He has no evidence of calcification anywhere. His last name is, he wasn't born in this country. His last name is from somewhere in Southeast Asia. So, and you can see there's, cystic areas, presumably bronchiectatic lung, which it is. So it could be TB, but the right lung, look at the right lung. I mean, and he's a non-smoker. The right upper lobe is basically just this little thing up there. It's a strange case. I'm having trouble putting it all into one diagnosis.
Some bad childhood infection, or young adult infection. The fact that his left PA proximally is so fat tells us that this happened after he'd achieved probably 10 years old or older, just by the caliber of that vessel. And it also tells us it's not a congenital like a CPAM.
Exactly. Yeah.
About that lower lobe.
Oh, I didn't even think about that. Yeah. No, because initially I saw it, I'm like, oh, it's going to be congenital abscess. I'm like, wait, no, it's not. There's actually too much PA and there's vessels and it doesn't make sense. And then I'm trying to think, is the coarc just completely unrelated to the PA finding, which again, probably like you said, due to some infection, and is it all this somehow related to vasculitis, which seems probably not, because they're so, the time frames are very different. And I don't know, I haven't seen many cases of Behçet's, but I wouldn't think this looks like Behçet's to me.
No.
And then the lung attenuation, I mean, it's so odd too. And is that due to some component of the vasculitis, even though the lung attenuation thing has been there before he really developed the vasculitis? Anyways, a confusing case, probably a lot of things going on here. He's a non-smoker.
I think that might be his Dwyer-James syndrome.
You know what? That's an excellent thought. That's an excellent thought. I mean, I was thinking something that's an excellent thought. I was thinking something vascular, just because of the vasculitis in the left lung but you're probably, you're probably right. It's probably just all due to bad infection at some point early in life.
Yeah.
But he's asymptomatic. That's the amazing thing.
Yeah.
It's completely
Crazy.
I should have thought about that, but I didn't think about that. Okay, those are my cases.
All right, thanks, Seth. All righty.
Next slide.
So I have a few cases I can show. So this is a baby who was born in respiratory distress, and you can see lungs are already looking a little edematous and a lot of bowel gas. So anyway, this patient had a CT scan, and they'd done some echoes and suspected some congenital anomalies, but this is great because we rarely see this unrepaired. So you see there's a left aortic arch, PA is big. We go down here, you see the right heart is a little dilated, but follow the pulmonary veins in. So here are the superior and inferior veins coming in, and you can follow them down into this vessel here, and of course it's separate from the left atrium. And then this heads south. It gets a little narrow right at the diaphragm, and then extends into the upper abdomen. Now there's a stent in the ductus venosus here, and you can see it combines with the hepatic veins and the right there, and then this drains into the IVC. So this is an infracardiac total anomalous pulmonary venous return or connection. There's some high-grade narrowing distally, so that this is all edema in the lungs because of that. And then there's an ASD that they saw better by echo, but you can actually see right in here a little bit. There's a secundum ASD right back in there. So I think we've seen one other case, or maybe two on this webinar ever, of an unrepaired version of this. But I thought
a long time ago when I used to do these all the time, I showed a couple cases. This is nice. On the coronal, it's a beautiful, if you do the coronal along the sinus, it's a beautiful, kind of looks like it's like this branching. If you do it like along the do the long axis along the pulmonary venous confluence,
Uh-huh.
it has a very characteristic appearance, and it's really a very pretty case.
Yeah. So yeah, and it's important, as I learned from my colleague today, is that these narrowings are important because that'll determine what they're going to do, and because it's pretty tight distally, they're going to repair this surgically and shut.
So, Jeff, what did his left atrium look like? I was looking at the veins, but I didn't see how much of a left atrium there was.
It's there. There's the appendage. It just there's a shunt, so that's why it's still intact, right? There's a problem. I mean, I presume it's right in that area there. We don't see it.
Yeah, there's the AST right there. There it is, right there.
So yeah, there is it just never attached.
Couldn't they just anastomose that point of confluence to the left atrium?
I suspect that's what they would do, sort of like when they do a heart transplant, and they leave
exactly what they're going to do.
Nature. Yeah, Seth probably knows a lot more. And then I guess they will eventually ligate the distal portion of it.
Oh, this makes me miss scanning these little kids.
So this is a cool case. This is something, I see histo all the time, but this is something I had not seen before. So this patient presented with some chest pain and had a CT scan, and you can see has pericardial effusion, pleural effusion. So it looks like it's a middle-aged male. So it looks like a good case of pericarditis. And he at the same time had this cluster of nodules there in the middle lobe, and then there's a second cluster up here, and they have the little satellites. And then going along with that is some hilar and ipsilateral-mediastinal lymphadenopathy. So with pericarditis, I suppose you could get some lymphadenopathy, but this asymmetry with these nodules for us is pretty classic for histoplasmosis. And so he was treated for histoplasmosis. His serologies were his urinary antigen was positive. And all that, and then he was treated, and then presented later with some similar symptoms at an outside hospital. But you can see his pericardial effusion is resolved, and the lymph nodes are getting smaller, which they don't typically go away, but they're definitely smaller. And then there are those nice nodules there. So you get the dominant nodule and the little clustered nodules around it, and you can see some thickening along that vein, or the same thing here. Pretty classic for histo. So
you get pericardial effusions with histo frequently?
No, not at all. I mean, it's a known complication. It's just not one I've ever seen. I mean, I guess it's possible he had a virus and histo at the same time, but
it was histo. Yeah, no, that's crazy.
But his serology markers were all whatever. I'm sorry, his urinary antigen was positive, and inflammatory markers were elevated. So the ID doc I talked to was pretty convinced this was histo, and it does occur, but it probably is self-limited anyway. So I suspect if you treat them with steroids for the inflammation and NSAIDs or whatever, it gets better on its own. But yeah, never surprised by the fungus. And then this is kind of a cool case. So this patient presented back with cough, and you can see there's these sort of mass-like areas and some nodules in both lungs. And then had a CT scan done, and had these large areas of consolidation, kind of shaggy margins, a little bit of ground glass around them, and very discrete air bronchograms. Kind of looks like organizing pneumonia, but it's a little ratty around the edges. Usually it's more, in my experience, it tends to follow lobules more, and kind of has a little bit of a nodule component to it there. I think that was the only finding. Yeah, there's some mild lymph node enlargement, but nothing to get super excited about. At the time, I don't remember exactly what they gave. They gave a broad differential. So they did a bronchoscopy, transbronchial biopsy, and got some granulomatous inflammation, both necrotizing and non-necrotizing. No organisms grew. So he was given a presumptive diagnosis of sarcoid. Was treated because of his symptoms and extent of disease. And then here he is recently after being on corticosteroids. And it's kind of cool because now if you saw this scan, I think most of us would be very confident in calling this sarcoid. You've got like giant galaxy signs. You've got perilymphatic nodules all along the pleura, the bronchovascular bundles. There's a little bit of interesting cavitation in some of the areas. So this is what they used to call years ago the alveolar sarcoid. I never liked that term. It's just conglomerate granulomas, but it's interesting that when it treated, it looks more like just like the galaxy sign. So maybe it's probably a spectrum, and this guy presented with very advanced late disease. Interesting. He was from somewhere in sub-Saharan Africa, so he wasn't from. Yeah, he was there. So it occurs all over the world. So, but not TB in this case.
Can you show the original one? I don't think I would have ever even put sarcoid in my.
Yeah, it's not would have been high on my list. Let me put them up side by side. Yeah, I mean, this looks like lymphoma,
Yeah, I was going to go lymphoma. Yeah, and then the OP, eosinophilic pneumonia, lymphoma kind of differential.
Right. Well, that's why they brought them. Yeah, they got nice things, but yeah, it's kind of cool because I've seen a ton of sarcoid, but I only have a handful of cases that look like these discrete consolidative masses.
Especially the right upper lobe, massive consolidation. I mean, that's
look at that one.
Yeah, I just would have never.
No, you're absolutely right. That would have been, yeah. So sarcoid also never surprises me anymore.
Yeah.
So with IgG4 disease, do you get a granulomatous pathologic analysis, or is it a bunch of lymphocytes and plasma cells and things like that?
I have no clue.
Yeah, I don't think you get granulomas, particularly not compact sarcoid granulomas, type granulomas.
And
hyalinization.
And people didn't think about, EGPA or anything like that.
Yeah, vasculitis would be a good thought for the initial scan as well.
Yeah.
Those shaggy margins is kind of what really throws me off, because I've seen cases of sarcoid with mass-like consolidation, but you can usually pick up nodules along the periphery that tip you off. But yeah, this one, yeah, it's just interesting. So these were about, I can't remember how far apart they were. I want to say about 6 months apart. So kind of a trio of interesting cases, but yeah, I like the TAPVR case because, and he was, I think most of the times we don't see them because they either fix them right away or they die at birth, they're born dead, or right shortly after, because it can be highly obstructive. But he was, they had a bunch of echoes, but they hadn't done any full anatomy, but they'll be able to repair it pretty soon. Okay, well, it's almost the hour. Howard, if you wanted to show a few more, there's time. If you want to save them, that's fine as well.
I'll save them, yeah.
Okay.
Sure.
Well, thanks, everybody, for the great cases, and I'll talk to you next week.
Thank you.
Cheers, everyone.